I'm going to start recording. And if we could start off with some introductions. Renee, would you mind introducing yourself again to the group?
Sure. Renee Bolio Banks, Indigenous Kaj Naganashimong, Zibikwe, Indigenous Kaj, Indigo, Sagasquat Jamaica, Gandunjaba, Migizi Nindu Dame. So it's kind of a general greeting that we use. Renee Bolio Banks is my birth name, and my spirit name is River Woman. I'm from Leech Lake Nation, and I'm the Eagle Clan. I've been at NACC for about going on 5 years, and I'm an elder in residence. So I help with spiritual care and just the medicine wheel health. So miigwech.
Miigwech. And Dr. Robbie?
Yes, hello, my name is Kari Robbie. I'm a family practice and addiction medicine physician, and I've been in NACC for 13 years. And I've been working with the MAT program since 2016.
Thank you. And Nikki, who happens to be our presenter today.
I'm Nikki Giardina. I'm the infectious disease nurse at NACC.
Thank you. And I'm Lindsay. I'm the community and tribal engagement specialist here at NACC. And then with that, I'm going to share my screen and do some announcements before I hand it over to Nikki. Can everyone see that? Okay, great. So welcome to the Midwest Tribal Echo. We're the Opioid Use Disorder Education and Treatment Echo series. And then today we have Nikki, who is our Infectious Disease Care Coordinator. She's going to be talking to us today about safer drug use. A little bit about NACC. So we're an FQHC that started in 2003, and we're located in the heart of the South Minneapolis urban Indigenous community, right on Franklin Avenue. This is just a list of current open positions that we have at NACC. If you'd like to read more about these positions, feel free to go to our website down at the bottom, and you can read more. Some session guidelines, no protected health information as always. If you could mute yourself if you're not speaking. And if you can turn your camera on if you're feeling up to it, we'd love to see everyone's faces. And then if you can let me know who you are in the chat, so name, title, organization, and email, I can get the post-evaluation survey to you and any other materials from today's session. And then, yeah, this is our first iEcho session. So I thank you everyone who's registered, and I'll continue to send out that information to people to be able to register. So now you'll be able to go on to iEcho and access all of the slides and information. So it should all be in one place. So upcoming ECHO sessions, our next one will be January 17th with Open Arms of Minnesota. And then February 7th, we have ECHO on mobile nursing foot care. And then this is a list of other ECHOs that we recommend that cover similar topics. I can always give you more information on that. Just let me know in the chat or send me an email. And then we do offer CME credit for those who are eligible. We just ask that you fill out the post-evaluation survey. And then I'll put that link in the chat today and then also email that out to everybody. And then if you have a case presentation, feel free to email me. It's a great way to learn from each other. Great discussion. So please share if you have one. And I think that's it. And with that, I will stop sharing and I will hand it over to Nikki.
Great. And then do you want to mute? Okay. Do you want to just unplug it? Can everybody? Yes. Okay, thanks. Sorry. All right. I'm just gonna get my slideshow up. We are okay. Okay. Are folks seeing the presenter view or the? That's all right. I'll just. There we go. Good. Okay. Hi. My name's Nikki Giardina. I'm a public health nurse. I've worked at Native American Community Clinic off and on since 2017 in roles in our MAT program and now in doing infectious disease care coordination and program development, so mostly around HIV and Hep C care and also medical care for folks who are often unsheltered and using substances. And I've been working in harm reduction off and on since for about almost 20 years now, actually, since 2004. And so yeah, it's something that has followed me through different professional endeavors and that I'm very passionate about. And I think that another thing I'll say, though, is that, information is always changing. Best practices are changing, especially since there is not a lot of, although syringe exchanges themselves have been studied quite closely, the actual processes of drug use and different behaviors don't get a lot of funding for studies. And so some things are, based on conversations with and reporting of people who inject, and then also, sort of standard clinical knowledge that can be applied. But I guess all of that is to say things are changing and being updated. And so if anybody has anything they want to share with the group as we're going that they know that I didn't present on, please feel free just to interrupt or anything like that. So okay, and I'm going to be talking about safer drug use. And so why is this important? Harm reduction philosophy says a lot of different things, but one of the things it says is that people who use drugs deserve access to information on how to do it in the safest possible way. Just as, I believe that anybody deserves information on how to preserve their health maximally while engaged in any activity that, doesn't hurt other people. And then, just generally speaking, drug use and the behaviors around it have been sort of shrouded in darkness and secrecy for so long, which really is, a fact that's very enmeshed with the drug war and just stigma against drug use. And so just bringing it into the light, talking about it in sort of straightforward clinical way, a way that isn't about, is this drug use good or bad, but is just about the fact that it exists, and clinical information about it can be helpful. So abstinence shouldn't be the only answer to drug use. Not everybody is going to be abstinent. Let's make sure that we have education available so that people can protect themselves and others. And then, harm reduction services in general, giving people access to this information is just good public health, dramatically reduces rates of overdose, HIV, Hep C, and has not been shown to increase drug use. I'll also say that, throughout this presentation, I'm going to be talking frankly about drug use and some about sex, and there might be I don't think there's graphic images, but there are links to websites that are resources for information that also talk very frankly about sex and drug use. And so if anybody is not up for that, just to know that that's coming. Okay, so what are drug-related harms and risks? So infectious disease like Hep C and HIV, skin and soft tissue infections, damage to blood vessels, blood loss, nerve damage, and then endocarditis, so infection of the heart, osteomyelitis, infection of the bone, sepsis, so infection throughout the bloodstream, overdose, and then of course social and relational and criminalization related harms. And so I would also argue that the criminalization itself and the stigmatization of drug use is responsible for exacerbating a lot of the other harms that someone who has again been forced to kind of keep their drug use in the dark, hasn't had access to respectful services or education, may be at much higher risk of encountering these drug-related harms and risks. And so some of them, I would say, are not inherent to the drug use itself necessarily, but heavily impacted by society. So when it comes to harm reduction education, a lot of things are presented along this hierarchy of risk. So going from, what's the safest choice one could make in this situation, all the way to the highest risk, the least safe. And I mean, of course, it's not always that linear, but I think that the goal in presenting things in this way is to make sure that everyone has an option. So, there's a motivation sometimes to do the least safe thing, and we can talk about like why those motivations might come up in a little bit. But so somebody who's not ready to go all the way from the least safe to the safest, can they still make a positive change and reduce their risk in some way while being presented with all of the options and associated risks? So this is just an example of how overall injection drug use might be laid out in a hierarchy of risk or hierarchy of safety model. So safest would be never injecting, then you wouldn't be exposed to any of the risks. The least safe would be using without implementing any of those safeguards, like using your own equipment or cleaning your equipment. And then in the middle, we have using, but always using your own sterile new supplies or cleaning your own equipment. And so, these are all practices that real people use, and they use them because of certain life circumstances. And so, we want to make sure that people have all of the information about the choices that they're making and the way they can make both large and smaller changes in order to protect their health. All right, like I said, it's not always that simple. Here, sort of a little bit of a hierarchy of safety in terms of routes of drug use. I mean, again, I think when I was laying this out, was kind of laying it out in terms of the speed of onset, just sort of thinking about overdose risk. But of course, anytime you're injecting, even if it's a intradermal or intramuscular injection, that's going to put you at greater risk of a wound. So it's more complicated than this. But in general, the slower routes of entry of drugs are going to be safer in terms of the risk of overdose. And so this is just a chart with a bunch of different ways that people use drugs. I don't know how familiar everyone in the audience is with the specifics of different modes of using drugs. And so I don't want to go over things that are quite familiar to people. But just briefly, people take drugs orally, obviously. It's a pretty slow onset. They snort them and smoke them and inject them directly into their veins. That's intravenous. They can inject them into a muscle or under the skin. So that's like an intradermal injection, like if you get a Manto test. Some people will inject drugs into the rectum, and then people can use drugs by just putting certain formations of the drug on their skin, like a fentanyl patch, and then it absorbs through the skin. So injection, we talk about injection a lot as a mode of entry because it's high risk, because it's complicated, and because a lot of people do it. So specifically intravenous injection directly into the vein. Again, like I said, people also inject drugs in other ways. And to a certain extent, intramuscular injection, could be seen as safer to intravenous because, again, the onset is slower. It takes some time to absorb into the blood vessels from the muscle tissue, as opposed to intravenous, where it goes directly into the blood vessel. But at the same time, certain drugs are very caustic and damaging to tissue, and so injecting them intramuscularly is actually something you'd want to avoid. So a lot of this, where activities fall on the hierarchy of safety, has also something to do with the specifics of the person, their health status, and what substances they're using. Oh. Okay, so why do people inject drugs? Because it's efficient, right? It doesn't, if you're smoking a drug, a lot of the drug just gets lost to the air, but intravenously, you're sending it all directly into the bloodstream. Economical, so you can use smaller amounts for a greater effect. The effects come on quickly and intensely, and in some cases may last longer than if somebody is, for example, smoking or snorting the drugs. So the risks obviously include overdose, which is related to the fact that it is so efficient and comes on quickly. Infectious disease like hepatitis C and HIV, soft tissue infections, and then having to carry around equipment that can put somebody at risk of, criminal justice involvement. So, all right. So then in terms of finding a spot, if somebody's injecting drugs, so this is a very important component of the level of risk associated with someone injecting a drug. And so generally speaking, arms are going to be the best bet. And then, risks kind of increase from there to hands, feet and ankles, legs, and then the groin and the neck, breast, and penis are all sort of like, red flag areas with relatively higher risk. Throughout the presentation, I'm also just sort of sprinkling in some of these images from different harm reduction providers, mostly throughout the US and Canada, who, I think have created really sort of visually interesting and clear educational materials. And I think, in addition to this sort of being a talk about the specifics of safer drug use education, I also want to give people a lot of access to resources that they could potentially share with their own clients. And so at the end, there's a whole like resource list that you can click through. But so this one from Katie, which is, I don't know if I'm going to remember what it stands for, but Canada AIDS Training something. Anyway, I think they mostly just go by Katie though. And it just shows, color wise where safer and less safe spots to inject are. And then this is an image taken from the Harm Reduction Coalition's Getting Off Right booklet, which we'll look at a little bit more in a minute. And it shows, the main anatomy of veins in the arm. And so, I think that if someone's injecting drugs, having a basic awareness of their anatomy can be very helpful, and I think some people may feel like, oh, it's like we're teaching people how to use drugs, but again, the studies are showing that people aren't really using this information to inject drugs if they wouldn't have otherwise, based on sort of drug use rates and how they trend when more education is available. And it also really does help keep people safer. So one example is that, so we know injecting into the arm is the safest usually, right? But what happens over time if people are injecting into their arms in ways that are leading to more rapidly escalating damage to those veins, they're then going to wind up switching to veins that are less safe. And so the longer we can sort of preserve access to those arm veins, the longer people can keep using their arms. And overall, that means they're at lower risk for a lot of the health consequences or the health risks of using other sites. And so when we teach people, for example, how to get their veins up, right? How to, use maybe like exercise or heat to make their veins more accessible when they're trying to inject. It's not about trying to increase drug use. It's about trying to help people to keep their veins as healthy as possible and not damage their veins and other tissues in order to not have to resort to higher risk spots in the body. So some other suggestions we might give to people, always make sure that the needle you're injecting towards the heart. Rotate sites. So try not to use the same site over and over again if possible, because that can just lead to, blowing the vein out, the vein that no longer will be able to be injected into. And it then obviously negatively affects like the perfusion of that area of the body too. Not as much blood is getting to it, which puts it at greater risk for infection and other negative health outcomes. Injecting downstream from a recently used vein. So meaning if you've injected in a spot, there might then be a blood clot there. And so you wouldn't want to inject upstream thereby sort of like potentially like pushing through that spot with the blood clot. So kind of basic stuff like that. Hands and feet, are pretty common and not the safest, not the least safe spot, injecting slowly because the veins are very small and delicate, taking off rings so that if a finger swells, you haven't cut off the blood flow there. And then also just being aware of the risks of legs and feet. There's a greater risk for infections and pretty serious clots. And then if somebody does wind up having a bad reaction from an injection in one of their legs, it just like negatively affects their mobility and day-to-day life, potentially much more than having that injury to their arm. So very high risk injection sites. So the groin. Something very common amongst, so to the groin and the neck is that you have arteries, veins, and nerves really close to each other. And so it can be very, very hard to distinguish between like which one you've got. And injecting into arteries and nerves can cause very serious problems. So we can talk about that in a minute. You also, anytime you're injecting into your groin or in one's leg too, you run the risk of a pretty serious blood clot that can form, called a DVT, and then it can come loose and cause some pretty serious problems in breathing. It can be fatal. So those are just the risks of injecting in that area. But I would say that when folks run out of spots to inject in their hands, arms, feet, and legs, often the groin is a place that they go to. And so even though it is high risk, the question then is, do we, want to make sure that there's education for people on, if you are going to inject in the groin, here are the risks and here's how to do it in the most safe way. And so I would say most, harm reductionists would say, yes, let's put all the education out there. So I'll show you in just a minute some educational material on groin injecting. The neck, again, proximity to other structures, and then also just the risk of having an infection in the neck or above, it being so close to the eyes and the brain. And then the breast, the veins are very, very fragile, so it just can be quite difficult to access. And then injecting in the penis can lead to persistent erection, which can be a medical emergency, and then also, an infection in that area would also be very serious. So we advise folks to try to avoid arteries whenever possible. So, the deeper the vein is that somebody is trying to reach, the higher the risk is that something's going to go wrong. And one of those things could be that they accidentally hit an artery, that they accidentally gain venous access, that they accidentally, their needle it accesses an artery. So usually if somebody does hit an artery, it's going to be pretty clear. There's going to be pain. There'll be like the blood will push back sort of forcefully into the syringe barrel. It might be frothy and like bright red and pulsing like a heartbeat. And so if that happens, then we want to recommend people pull the so we want to recommend people are actually proceeding slowly so that if they do notice that pain, they can stop right away and pull out the needle. And then we recommend people put pressure on the wound over a long period of time. So, at least maybe a half hour, lie down, try to hold the spot over the heart. And, really we would recommend getting professional medical help if somebody thinks that they've hit an artery. So tissue damage, which can then lead to all kinds of other problems down the line is something that we're trying to avoid there. And in general, encouraging people to inject, to go more slowly when they're injecting, can help them to earlier on recognize that something is wrong, and so reverse it and avoid some of the most serious outcomes that could happen if they are moving in a direction that is unsafe. So yeah, just like I was just saying, just having access to the time and space to be able to inject, indoors in an indoor space that's well lit, that has running water, clean running water, where there are other supportive people around, all of these things reduce the risks of negative outcomes of injection drug use greatly. like I was saying, helping people to find veins can help them take better care of their veins if they're having fewer missed shots. And so being better hydrated, applying heat or warmth to the area, doing some exercises like some pull-ups or push-ups, or just tensing their muscles, having the body part in a dependent position, so under the heart, so that blood pools more. Caffeine and nicotine both constrict blood vessels, so those can potentially make it harder to find access. If a vein or if a vessel is pulsing, don't inject there because that's likely to be an artery. And then sometimes someone may be rushing because they are in withdrawal. And so it can make it hard to slow down and pay attention, and it can make it hard to withdraw the needle if something seems like it's wrong. And so doing a little bit of the drug through an easier method like sniffing or smoking could then potentially help the person calm down enough to be able to proceed in a slower and calmer and more sort of wise-minded way. And then, clean hands and sight is always going to help reduce the risk associated with injection. I'm sure a lot of people have seen this image before. It just is showing how quickly needles blunt when used over and over again. And so, people often will prefer smaller, they'll prefer, needle gauges that are smaller. So 29s, 30, 31 gauge needles. And, those do create a smaller wound when used, but they also blunt much more easily and become coarse and just can, then wind up being more dangerous, harbor more bacteria and viruses, and cause more damage as they're being reused. So also some of the 31 gauges, which are shorter than, like if you have a 5/16, so shorter than a 1/2 inch syringe, it can be harder to make the shot. And so especially with you just don't have as much area that you can access with it, under the skin. And so especially if you're using something that you really don't want to wind up outside of a vessel, so something caustic, it could be like, xylazine or meth, then using those teeny tiny needles might not be as great of an idea. Yeah, so I mean, just really quickly, because I know a lot of people on this are probably pretty familiar with these tools. At the same time, though, if you're not as familiar with these tools and want more information about like how each of the tools is used in detail, you can reach out to us or use some of the links that are going to be at the end of this presentation. But so, you're using your syringe, cottons. So these cotton balls are pretty big. I think usually they'd be, like smaller cotton balls, which are used as a filter to draw up the drug out of the cooker. So that's that, spoon or that little metal cup. So those are used to dissolve a solid drug into in order to prepare it for injection. Tourniquets, are just used to improve access to a vein. Alcohol wipes to clean the area. Sometimes people will use them to clean equipment too. And then some sort of heat source in order to cook the drug to dissolve it in the substance. So, just some real basics. Wash your hands, wash the cooker, cover the surface, meaning the surface of whatever you're laying everything out on, even like laying out some newspaper can be good, particularly if other people have been injecting in this area. I mean, hepatitis C can live on surfaces for a while, and obviously other viruses and bacteria can. And so just having sort of like a fresh, it's not sterile, but it might be better than having other people's old dried blood on the surface. So completely dissolve the drug. Sometimes drugs that have a harder time dissolving need to be cooked twice. So sometimes that needs to happen. Filter with a clean cotton. Learn how to inject yourself. I mean, I don't know. That's like said like an order, which is not, I really mean like that. I think better it would be like learning how to inject yourself can be empowering in the context of relationships. I think that, and this is a video, I don't think we'll have time, but you can go to it on your own later. And it's basically some young people talking about injecting drugs and the importance of their journey and taking ownership over learning how to do it when previously they had just had other people injecting them, and how much more powerful they feel like their role is in like advocating for themselves and protecting their own safety, in knowing what every step is, in knowing the whys of certain you know, like safety changes they might make, and also in you know, just being able to say no to things that feel unsafe, and just make wiser decisions for themselves. So, you know, particularly if there's a relationship where like maybe one partner is being abused or controlled, you know, that person may then, if they don't know how to inject themselves but are dependent on a substance, then that can just add an additional level of dependence and reliance. And so yeah, so some other tips, and you know, there's just so much information on safer injection, so this is sort of just like a peppering of some of the big things, but again, diving into some of these materials will give even more information. But when people are injecting, we want the bevel for the needle to be facing up. So the bevel is that little like sort of diagonal cross cut in the needle where the bore is. At about, you know, 15 to 45 degree angle, it depends, but the more perpendicular the needle is to the vein, the more likely it is that the needle isn't going to actually enter into the vein, but that it'll go right through it. So we want people to check for blood, so meaning to register, to pull back on the plunger of the syringe to make sure that there's blood coming, so that to make sure they're actually in a vein. This I just loved, and I've linked to a site where actually it can be purchased. Maybe we should get some here. It's a hierarchy of safety, or hierarchy of risk around water, the water used to dissolve drugs in. So this is too tiny to see, but I was able to find blown up you know, all the different colors. So the first three, the green ones, so these are lower risk. So obviously an unopened ampule of sterile water intended for injections is ideal. And so, you know, and we do, you know, harm reduction organizations do hand those out. So cold water freshly run from the kitchen tap. So this is created, I think, by a UK organization. And so I guess they have different water coming into their kitchen taps versus their bathroom taps. I don't think that that's the case anywhere here that I know of. But if you have clean tap water, you know, having it run for a little bit until it's really, really cold is a relatively low risk of bacterial infection in terms of using that. So, and then water that's been boiled in a kettle and then cooled is also a great option. Sort of the medium option, so bottled water. So you just want to make sure, you know, if somebody has actually put their mouth on the bottle already, it's really not the best option. But if it's a new bottle of water, probably it may not be as safe as cold, clean tap water. It has a higher risk of having bacteria in it, but not the worst option. And then hot water from a tap. So the hot water is not hot enough to decrease any of the microbes in the water. And then actually, and you know, everyone may know this, but hot water actually is dirtier than cold water. It has more in it, because there's probably different reasons, but one of the reasons, at least, is it's not run as often. So it kind of just sits for longer. And then the highest risk, so a shared cup of water could have somebody else's blood in it, or other kinds of, you know, bacteria. Just, you know, get a new cup of water, wash the cup before you refill it. And then an ampule, so those sterile water ampules, but that somebody else has already put a dirty needle into, meaning a needle that they've already used. And so even if you can't see the blood, you know, that virus could still be in there. And tap water, cold tap water, is much safer. There's nothing like the sterile water itself. Once somebody's put a dirty needle in there, it is then no longer safe at all to use. So tap water is much better at that point. Oh, and then puddle water or saliva are very, very high risk. And really any other source of water is going to be lower risk than that. Toilet water from the bowl is also very, very high risk. Water from the tank could be lower risk, or catching water as it kind of flows into the toilet when it's being flushed. But obviously these are really tricky options. So, all right. So hepatitis C, I'm going to speed up a little bit, but so hepatitis C is, most commonly transmitted from blood-to-blood contact amongst people who are using injection drugs and sharing needles or sharing other supplies. So some of the ways that we can help to prevent hepatitis C transmission, as well as HIV transmission too, are to, encourage people to be really clear about whose supplies are whose, right? So you're maybe injecting with other people in the same space. Like, how do we distinguish what are my supplies versus what are your supplies? Not just the needles, but all the supplies, the tourniquets, the cottons, the cookers, all of that. The water source, as we just said. And some of this is really, if somebody works in healthcare, it's kind of the same thing that we learn and employ every day, sort of teaching a clean technique, low touch, little bit of like a mended sterile technique. Like if you have something that is clean, don't have it make contact with something that's dirty, sort of have, be able to distinguish between what's still sterile and what's not, that kind of thing. I liked this idea from Katie about how to distinguish which syringes belong to whom. And so using like different color nail polish for different people, or scraping a number off of the barrel, and then you know that number is yours, something like that. And of course, if you are using with other folks and there is a source of water, there are ways to all use that water without contaminating it, like, so again, it's about that sort of like people understanding sterile technique. Like if something sterile touches something else sterile, then that still remains sterile. Or, if you have a clean cup of water, say, if you all use a brand new syringe to draw water out of, then that's okay, as long as that syringe hasn't been used yet. So kind of keeping track of things like that. Bleach. So in terms of, some people will use bleach to clean out syringes in order to use syringes that other people have already used. And there is some controversy in, the harm reduction community about whether people should be taught how to use bleach, because the fear, I think, is that people will think it's entirely effective, that a bleach syringe is as good as a new sterile syringe, and that's not the case. So it's not really considered effective for hepatitis C, as far as I know, and it can sometimes kill all HIV, but sometimes not. And so it's just kind of iffy. But again, it's one of those harm reduction techniques that, is good for people to have all of their options so that they can make choices in any situation that can reduce their risk. So I won't go through all of this, but these are instructions on how to bleach a syringe. Essentially, you're like flushing it out with water a few times, then having it sit full of bleach, and then flushing it out with water again. All right, so inhalation is another mode of drug administration. So smoking benefits, it's easy, it can hit fast, it has some risks associated with it. It can, it can damage the skin and mucous membranes around the mouth, the lips, inside of the mouth, the throat. It can also cause some pulmonary damage to the lungs. And it can carry hepatitis C risks too. When people are sharing pipes, if they both have open skin on their lips. And so then blood from one person using the pipe who has hepatitis C can then move to the open wound on the other person's mouth. And then that can be a blood-to-blood transmission of hepatitis C. And overdose is possible, but with inhalation too. So crack and meth are drugs that are often smoked, and we frequently provide supplies for people to smoke those drugs more safely. And so just to go kind of quickly, a lot of the things associated with safer smoking involve like preventing that transmission, that blood-to-blood transmission. So people either using their own tools or having their own mouthpiece. So often mouthpieces will look kind of like a little rubber cylindrical thing that you just pop onto the end. And so everyone having their own mouthpiece can help to prevent that. And then also maintaining the integrity of the skin around people's mouths and inside of their mouths too. And so encouraging people to use lip balm or Vaseline, to chew gum, to try to increase the saliva within their mouth. All of that can help both to keep the skin and tissue healthier, but also to prevent transmission of viruses and bacteria. So these are all of the various tools used. I can let you kind of look at these more closely on your own. Some of the things that we would tell people to try to encourage them to make some safer changes would be so once someone's inhaled, oftentimes they'll sort of hold it in, thinking that that increases the high that they're going to get. But that apparently that's not the case. So exhaling immediately won't get you less high, and it can help to prevent some damage to your lungs. Also, if people have a broken or cracked or chipped pipe, we'd also encourage people not to use those, just because it increases the risk of cutting themselves, which then, just increases the risk of getting infections. Sometimes people have to share mouthpieces. And so if people are sharing mouthpieces, we'd encourage them to clean them with bleach or alcohol and to use something protective on their lips. And, this isn't 100%, right? It's not as preventative of transmission as it is to only use your own supplies. But in a situation where the person is going to share, these are some steps they could take to reduce their risk. Using metal pipes can be more dangerous than glass ones because they get very hot. And then some of the sort of like soda bottle type metal that people use, or different plastic tubing or very thin glass, these can lead to greater risk of toxic fumes being released, or the pipe breaking much more easily. And so, the safest tool to use to smoke is one designed to smoke. And so that's why, harm reduction organizations hand these products out to people, and then they can also often be purchased at smoke shops. These are the screens. So they're what, holds the drug in place on the other side of where the mouthpiece is. And, it's great if people can actually use the screens that are designed for the pipes, which are something that, again, syringe exchanges keep in stock. Steel wool is risky because it can come apart, and then the metal pieces can become lodged in your mouth or your throat or your lungs. And then also the steel wool that come with cleaning supplies in them, that can be quite toxic to inhale. So it's much better, if you're going to use steel wool, to use ones that don't have cleaning supplies in them, that are just the metal. So with meth is usually smoked out of this kind of pipe called a bubble or a bub. Again, same thing with the mouthpiece or using your own pipe. That heat can be a means of damaging the skin and then transmitting HIV or hepatitis C between people. The thing about meth too is that it causes major vasoconstriction, and it causes a lessening of body secretions. That's that antihistamine effect. And so mucous membranes can become very dry and vulnerable to friction, making them more vulnerable to infectious disease transmission. And so just using lots of lube if there's going to be sex happening, and then also just trying to maintain really good hydration and mouth care in order to avoid some of those damaging effects. All right, we're nearing the end. So so this is the case for meth as well. With xylazine, it's extra important for us to teach people how to make sure that they don't miss shots, because the drugs can be very, very damaging to other tissue. And so getting that shot in the vein is safer than having it leak out into other tissue. So we would use sort of all of those skills that we learned before in teaching people how to perform, better injections, And then some other things that I've seen recommended. So to use a longer syringe, so meaning a 1/2 inch, just to reduce the risk of missing, like we talked about before, to pause before withdrawing the syringe. So just to make sure that hopefully the drug that has contained the xylazine has been moved by the bloodstream away from the site of the injection, so as to avoid some of it kind of coming back out with the syringe and damaging the other tissue. You know, some people may be interested in knowing how does, so you know, we generally say like smoking or snorting, opiates, you know, all drugs, it has a lower risk of things like overdose and infection. Is that the case with drugs containing xylazine? I don't think it's really known yet, as far as I could tell from doing some research. We just don't really know the effects of xylazine on these other body systems. So another thing is, you know, xylazine can cause really long-term sedation. And so we encourage people to be sort of aware of their body positioning if they think they may be using xylazine. Because if they are then unconscious for a long period of time, if they're in a position where they're restricting blood flow to some part of their body, that can actually wind up with like some serious tissue damage there. And so, you know, being around other people is ideal, but sort of sitting comfortably in a chair without any part of the body pressed under anything can be helpful. Teaching people about wounds is a really, really awesome way to provide some harm reduction education. We won't go into details because we're almost done. And then, of course, you know, preventing overdose is another really great way to reduce the risk of overdose, and, you know, such great things that can easily be employed by folks that are using drugs. PrEP is an amazing way to reduce the risk of drug use. And, you know, so PrEP is a medication taken daily that helps one who, so if a person is at high risk of contracting HIV but is currently HIV negative, they can take PrEP in order to prevent themselves from contracting HIV, even if they're engaged in high risk behaviors for HIV, such as unprotected sex with people who are HIV positive or sharing syringes with people who are HIV positive. So it's a great way to protect yourself and protect other people in your community. And then, you know, I'd say in addition to PrEP, also if a person is HIV positive, taking their medication, their ART, can be another really great harm reduction tool, because that can lower their viral load dramatically to the point where it's, you know, very suppressed and undetectable. And then at that point, with undetectability, you know, studies have shown that then HIV can't be transmitted from one person to another through sex. And even though the studies are not as focused on IV drug use, you know, it seems pretty clear that a lower viral load is going to be lower risk in terms of sharing supplies. I think that the last thing I just want to say, so different ways to get the message out. I mean, I think a lot of it is having educational material that's, you know, sort of conversational, palatable, respectful. But then another thing is also just having folks with lived experience who are designing the material, consulting on it, you know, being paid to help produce it, and then are sharing it too, and are actually staffing the programs, you know. And people who utilize syringe exchanges, although, you know, this entire presentation has been on like how to provide that education, they are really the expert sources of this information, and this expertise has come from their experience and their work in their own communities. And so just being really respectful about that, and kind of you know, like when encountering a patient or a client, just kind of trying to have that conversation, like, oh, where are you at in terms of this? Like, do you feel like well informed on this? Would you like some information? Because some people may say like, no, I am, you know, a harm reduction expert, I don't need this. And then, you know, it doesn't need to be shoved down their throat again. So yes, obviously addressing contributing factors. And then this is the end. This is list of a variety of resources, some of which were used for this presentation, but some of which I think, and I was going to go through some of them with you, but there's not time, but there's just so much great stuff in here, and really amazing resources on safer drug use that has been created by people who use drugs, and just has a long history of helping people who use drugs not only reduce their risk, but also feel, much more respected, understood, and, treated with humanity, just like somebody, doing any other kind of high risk activity. That's it. Oh, I guess that's old. Sorry, that's 6-1. I'm like, what?
There are some really good comments in the chat.
Oh, yeah, oh, yeah. Do we want to go back? Should we just leave my volume on at this point?
Yeah. As long as.
Here, I'll put this kind of in the middle.
Let's see. Ren has commented, some really great comments. They said agreed, would totally not recommend large bleached commercial cotton balls for injection, high risk for cotton fever. Helping folks learn to inject themselves also helps folks avoid seeking a stranger, less safe person to spike for them if their regular injector is absent for whatever reason.
Yeah.
Especially.
Yeah, I saw Kat said, are you seeing that positional neuropathy, numb hands and feet, like after xylazine use? Yeah, totally. Yes, definitely. Oh, do you want to read this one, Lindsay? The other one from Ren about sniffing xylazine? Did you read that one?
Even before there's.
Oh, sorry, there's too many good comments.
So for context, bleach and teach cropped up specifically during the early mid-AIDS crisis as a means of reducing infection rates when the virus was less understood. Less useful nowadays, though still a means of reducing risk when using sterile supplies is not an option. And then the book Undoing Drugs was suggested for more information on bleach and teach, and I put the link in the chat there, right there. Thank you, Ron.
The comments on xylazine from Ren as well.
Oh, yeah.
So if sniffing xylazine / tranq, flushing nasal passages afterwards may be another means of reducing risk of soft tissue damage. Some studies report instances of tissue necrosis in folks who smoke and snort as well as inject. Oh, that's really great information. So we need like neti pots.
You can also use the sterile waters for injection. You can tilt your head back and use those for nasal.
Any other comments? Questions?
A lot of thank yous and questions. Well, yeah, thank you everyone for joining today. I think now that we have the iEcho platform, we'll be able to get all the information in one area for folks. So stay tuned for that. We should have the slides and any links from today. If you have any questions, please feel free to reach out to me directly. Yeah, and the next ECHO will be January 17th with Open Arms in Minnesota. So I hope you can join. Thank you, everyone.
Thank you.
Thank you.
Nikki.
And thank you, Nikki.